University. First of all, I welcome Mr. Majdi Mohammed Sabahelzain, and he will defend his academic thesis in public. And his thesis is called Vaccine Hesitancy in Sudan, Assessment of Determinants of Parental Vaccine Hesitancy and its Impact on the Uptake of Measles Vaccine among Children in Sudan. And I welcome all the members of the degree committee, in particular the three supervisors, Professor Hans Bosma, he's Professor of Social Epidemiology at Maastricht University, Professor Bart van der Borne, he is Professor for Patient Education also of Maastricht University, and Dr. Mohammed Mokier, he is affiliated with the Department of Education and Quality Unit of Yazan University in the Kingdom of Saudi Arabia. And I will introduce the opponents later during the opposition. Welcome to the audience, the followers of the live stream, and I wish the candidate lots of success. May I invite you, Mr. Sabahelzain, to present a summary of your dissertation. Please go ahead. The floor is yours.
Thank you very much, Pro-Rector. Dear Pro-Rector, dear members of the Corona, dear family, friends, and audience, I'm going in the next 15 minutes to present a summary of my thesis entitled Vaccine Hesitancy in Sudan, Assessment of Determinants of Parental Vaccine Hesitancy and its impact on the uptake of measles vaccine among children in Sudan. So my presentation is divided into 4 sections: introduction, objectives and methods, key findings, conclusion, and recommendation. So I will start by this graph, which shows the top 10 countries that affected by measles worldwide between 2017 and 2018. And Sudan here is one of the countries that affected by measles, and actually witnessed significant outbreaks during the same period. This graph actually created by Robert Chen from CDC, and it shows 2 very important things. It shows firstly that the loss of confidence and vaccine hesitancy occurs when there is a decrease of disease rate. And secondly, it shows that the relationship between vaccine coverage and the disease rate. And as with, when vaccine coverage is increased, the disease rate is decreased. But here in Sudan, we have different story. This graph shows incidence of measles cases and measles vaccine coverage during 12 years. And it showed that the vaccine coverage is high. At the same time, there is increasing of cases of measles. So there is no relationship between the increasing of vaccine coverage and reduction of disease. And this actually shows that there is a gap in surveillance system in Sudan regarding reporting of vaccine coverage and measles cases. The immunity profile of measles cases in Sudan in 10 years, between 2016 to 2016, showed that there most of the cases are not vaccinated at all. And reason behind this low vaccine were not addressed well in Sudan, and only focus on vaccine access issues and barriers. So our thesis here put a hypothesis about that measles vaccine hesitancy is one of the causes of this low uptake. Vaccine hesitancy is identified as one of the 10 top global health threats in 2019, alongside with air pollution, Ebola, HIV, and other global health threats. So what is vaccine hesitancy? Vaccine hesitancy was divided by SAGE working group the WHO in 2014 that as a behavior, that means delay in acceptance or refusal of vaccine despite the availability of vaccination services. And this behavior actually is influenced by 3 factors: complacency, convenience, and confidence, and which is known recently as 3C model. Who is vaccine hesitant? Vaccine hesitant individuals are not homogeneous group. Actually, they may have many concerns, many doubts regarding vaccine and so on. Within the vaccine hesitancy continuum, we found that some people may accept all vaccines, some may refuse all vaccines, and some may have some concerns and about vaccines, and those who are vaccine hesitant people. The second section is about objectives and methods. So the research objectives, we have 4 research objectives here. Firstly, we have to identify, measures, and quantify parents who are hesitant toward measles vaccine in Sudan. Secondly, to investigate determinants of measles vaccine hesitancy among parents in Sudan. Thirdly, to evaluate the influence and impact of measles vaccine hesitancy on uptake of measles vaccine itself. And finally, to develop a website to increase vaccine uptake, including measles vaccine in Sudan. And to address these 4 objectives, actually, we conducted 3 methods. Firstly, we conducted a qualitative study by interviewing 14 participants from ABI managers, Minister of Health, UNICEF, WHO, and vaccine providers. And secondly, we conducted a community-based cross-sectional study among 500 parents in urban districts in Khartoum. And finally, we developed a website, and this website actually informed by findings from this thesis. So we selected Khartoum State, in which is the capital of Sudan. Khartoum is there because of 2 reasons. Firstly, it shows the typical social and cultural groups in Sudan. Secondly, the vaccination services itself are available there. So this is very important to study vaccine hesitance, because in the definition, the existing of vaccine services is important to address vaccine hesitancy. So our key findings were categorized by the objectives. So for the objective 1, actually we conducted a validation study to to test the validity of the adapted measles vaccine hesitancy scale. And we found that it is reliable, but unfortunately, it has very limited validity in terms of it doesn't predict the vaccination status of the children. So we used parents' attitude about childhood vaccination, which is called BAC scale. And it shows that only less than 5% are hesitant among our sample size. But there's no single metric that can measure vaccine hesitancy. So we use the items of BAC to identify other concerns and doubt about measles vaccine. And we found that there's 1 in 5 parents have concern and doubt about measles vaccine safety, efficacy, and importance. For the objective 2, we investigated determinants and from the perspective of ABI managers. And we, firstly, from the perspective of parents, we found that when parents exposed to anti-vaccination information, they are more likely to be vaccine hesitant. And if parents perceiving ineffectiveness of measles vaccine, then they are more likely to be vaccine hesitant. And also our findings show that social factors may influence vaccine hesitancy. For example, the number of children, the rank of the child in the family, actually increasing the vaccine hesitancy among them. Finally, perceiving access issue among parents, for example, if parents perceiving that vaccine is unavailable or inaccessible, then they are more likely to delay the vaccine or to delay vaccinating their children. And actually, these final points was supported by ABI managers and vaccinators. And this shows that there is a real vaccine access issue in Sudan, as vaccine is delivered only 1 to 2 sessions per week, because we in Sudan use 10 doses per vial, which only allowed the vaccinator to open only 1 vial per week. Also, we found that individual beliefs and attitude toward measles associated with vaccine hesitancy. For example, some parents think that measles is the common household disease, so every child should contract that disease, so there is no need to vaccinate them. And finally, contextual drivers such as religious beliefs, and we found that some individuals related to religious groups can be qualified as anti-vaccination, and they refuse all kinds of vaccines. For the objective 3, here we addressed the influence of measles vaccine on the uptake of measles vaccine itself, and we found that the BACT score predicts the concurrent immunization status, and here in this graph shows the ROC curve, which yielded more than 69% area under the curve. And for the final objective, we actually developed a website. This website provides information about vaccine preventable disease and immunization in Sudan. And this website was informed by thesis findings by Garrett framework for user experience. And also we used vaccine safety net criteria also to improve the website. And this vaccine network criteria actually helped us to be a member of the vaccine safety net at WHO. And here you can see that Sudan is we have Tad'im initiative. This is the name of the website. Is the only in Sudan, and actually that means we are accredited by WHO as trusted source of reliable information about vaccine safety in Arabic language. So finally, conclusion and recommendation. I would conclude by saying that there is no single metric can measure vaccine hesitancy, so there is a need to measure vaccine hesitancy quantitatively and qualitatively. Measles vaccine hesitancy in Sudan is complex in its causes, and it is multifactorial causes, and actually this needs more focus to address all these causes. And also vaccine hesitancy impact on vaccine uptake, and that will lead to vaccine to reduce the vaccine coverage. And if vaccine hesitancy not addressed well, this may disrupt the ABI program in Sudan. The final point in conclusion is that attitude, beliefs, misinformation should be well addressed, and also vaccine access issues should not be neglected because of its relation to vaccine hesitancy. So our findings inform the following recommendations. Firstly, at the program and policy level, measles vaccine schedule should be addressed using a reminder system to remind parents by using text message and other like notifications. Also, shifting from 10 doses to 5 doses per vial is needed as our study shows that there is its effect on the vaccine hesitance itself. So future research should focus on the public health and economic impact of shifting from 10 to 5 doses per vial. For example, there is a need to conduct a cost-effective analysis. Also, vaccine acceptance should be investigated among vulnerable and rural population, because our study focus mainly on rural, on urban districts area in Khartoum state. And finally, the communication strategies should address all beliefs, misinformation about measles and measles vaccine, and these communication strategies should be evidence-based and theory-based. And finally, frontline health workers should be trained by using, for example, interpersonal communication to help them to address vaccine hesitancy among parents. This is my last slide in the presentation. Thank you very much for your attention. And now the floor for you, the prorector.
Thank you very much, Mr. Sabahelzain. We will move now to the opposition, and it will be opened by Professor Hubbe. He is Professor of Social Medicine and Infectious Disease Control at Maastricht University. Professor Hubbe.
Thank you very much, Pro-Rector. Dear candidates, congratulations with your very interesting thesis, with a very relevant public health problem. It was really a pleasure to read it. And of course, I also want to compliment the supervisory team. Very interesting thesis with different ways of tackling the problem of vaccine hesitancy, different designs, so very nice. And I want to elaborate with you about some topics, especially on chapter 4, the cross-sectional study you also mentioned in your presentation. And my first question is actually about your sampling way. You have 2 areas where you sampled you recruited your parents to participate in the study, and you call it a stratified sampling. Could you elaborate a bit more on what you have done?
Thank you very much, highly esteemed opponent, for your question. Yes, actually, yes, we used stratified sampling technique because we have 2 district areas. These 2 district areas has, both of them are urban areas, but have different characteristics regarding their socio-cultural and socio-economic status. So we have 2 areas with 2 different socio-cultural and socio-demographic and socio-economic status. So that's why we use stratified.
Yeah, but the interesting question, of course, is on what data did you base the stratification? Where did you find what's the data where you stratified on?
Yes, okay, yes. The data was was obtained from the locality of Omdurman in Khartoum state. Yes, we found that they dividing districts in terms of socioeconomic status. Yeah.
So then you have a kind of sampling frame. So you recruit a lot of parents, but I didn't see anything about non-response. So not everybody was responding. Not everybody agreed to participate, I think. How did you deal with that?
Yes, yes. Actually, we put this percentage of non-response just to take into account this issue. But luckily, we didn't found that. We didn't found non-response. This may be because we also used number probability sampling by recruiting everyone who is eligible for the study. That is why maybe this is the reason that.
But so everybody agreed to participate.
Yes.
Okay.
Yes. Everybody. Yes.
That's highly interesting. When you look at the sample that you took in the end, so these 500, how do you think it's generalizable for the whole of Sudan? Because that's what your intention was, I think. Would you elaborate on that?
Yeah. Okay. Thank you again for your question. Yes. Actually, we cannot generalize because we conducted this study only on urban area. Mm-hmm. Okay. So Sudan is divided into rural and urban, and the rural area is about 80% of Sudan is rural area. So we cannot generalize on all Sudan, but we, to some extent, can generalize to Khartoum urban areas. Yeah.
Yeah. So, but you want to come up with, of course, data that is representative for the program you want to entail in the end. So what I saw indeed was that you also recruited quite a lot of highly educated people. So about 50%. Of course, that was very high. But what I also saw was that when you talked about the percentage of uptake of measles in Sudan, it was 88%. Well, in your sample, 96% at least had one vaccination. So how did you deal with this fact that it was not completely comparable?
Yeah, yes, yes. This is one of our limitations that we recruited, or we found that most of our samples are highly educated, there's more than 50%. And this actually is higher than the national level. But for the vaccination, actually, we found that it is 88% in our sample size. We found that the vaccine coverage of full dose of measles vaccine is 88%, the same as the national level. And this may be because, as I mentioned, that we targeted urban areas with highly educated people and so on. Yeah.
So the 88% that you call is only the fully complied percentage in the country, and that was it's indeed similar. How does that count for the one vaccine uptake? Because that was 9% in your sample. Is that also similar to the general population?
Yes, for the general population, yes. Actually, Minister of Health used two methods to calculate the vaccination coverage: the administrative method and survey method. Actually, for the survey method, at the national level, the vaccine coverage is lower than the administrative method. And for the administrative method, it is about 88 to 90%. Also, our study showed the same figure. It's 88% of the administrative method. And this, as I told you, this may be because we used or we recruited people from highly educated people or highly educated areas and so on.
Do I have still time for one question, or is it? Yeah, okay. You had some interesting findings, especially given the fact that age of the mother and birth rank of the children, and also the size, the total number of children, the size of the family was responsible for some hesitancy. How could you explain this?
Thank you very much for this question. This is a very important question, actually. And we found this issue not only in Sudan, in many other countries, that when increasing the number of the member of the family, this will increase the burden on the family to go to vaccinate their children, because mothers and fathers will be busy with other business, so they will not be able to go to the to vaccinate their children, and this may be not a priority for them. Yeah.
And do you also explain that for the increasing age of mothers, so that Is that the whole thing?
Yes, yes, the same thing. Yes, yes,
Okay.
yes. Because when when increasing the number of the age of mothers, that means increasing the number of family members, children, and so on. So, yeah.
Okay, thank you very much for answering my questions. And I give the word back to the pro-rector.
Thank you, Professor Hube. Before we continue with the opposition, I would like to mention that unfortunately, one of the members of the committee is not able to join us, which is it's Professor Ruiter. And he will not be able to be here, but his questions will be included in the questions of the other opponents. And now we move on to the following opponent, Dr. Alia Abadri. She is Deputy Director of AFAD Trauma Center at AFAD University for Women in Sudan. Dr. Badri.
Thank you, Professor.
Dr. Badri, would you
properly? Okay.
Yes,
I'll
this is
bring this.
better.
There
Thank you.
Go. Start better now. Thank you. Well, congratulations, dear candidate, for finalizing your research. Congratulations to your professors. I've got one main question, really, and it's about the social, economic, and social-cultural factors of the whole sample. So I believe that you've got the medical officers or the experts, and you've got the population. And I just wanted to understand more about the relationship in their backgrounds and how they have affected the responses and therefore the results of the research in terms of having the same responses, having the same answers. So how can you elaborate or explain that, if my question is clear?
Thank you very much, esteemed opponent. If I understand you well, you mean the highly educated people.
What I mean is that there are, you were talking about particular determinants of hesitancy, and you asked the experts or medical officers, and then you asked the parents. So how congruent or incongruent were those responses, and how can you explain those determinants?
Now I understand your question well. Okay, actually, we have, is for the qualitative study, we asked the EBI managers, immunization program managers, and vaccinators who are vaccinate children in the healthcare centers, and they are actually they are health community health workers. So if we compare between the two answers, parents and these officials, we will find that both of them agree that access issue is one of the very important issue, and one of the for example, from parents' perspective, these like perceptions, they perceiving that inavailability of vaccine, inaccessibility of vaccine, of measles vaccine itself, is one of the reason behind their hesitancy. At the same time, we found that, and this was supported by the EBI managers, that there is real access issue for measles vaccination, because measles vaccine is presented like 10 doses per vial, and these 10 doses per vial only allow the vaccinators to open one or to conduct one session per week, because if they open that vial, they should discard it by after 6 hours. So there will be like wastage of vaccine and so on. So I think these are one of the distinct results from the both of them. Both of them agree that there is access issue related to this aspect. The secondly, if you look also at the beliefs and the ABI managers mentioned that there are many beliefs regarding vaccine itself or regarding the measles itself. For example, measles is a common household disease in Sudan, so there is no reason to vaccinate their children. At the same time, parents actually not explicitly mention that, but we can, if we look at the data, we can understand this also happen. There's something about why they delay, why they don't go to the measles vaccine.
Thank you for that answer. I wanted for you to explain more about the social cultural determinants, the socio-economic determinants. I understand that there are policy issues in the 5 dose and 10 dose, and it's not really the problem of the EPI or the parent that goes. But I just wanted to touch more on the frameworks of the socio-economic and socio-cultural determinants that have that you may have studied that are factors or variables in the hesitancy.
Yes, thank you for your question. Yes, actually we used a broad framework that developed by WHO, stage working group. And that framework actually dividing the drivers of vaccine hesitancy into 3 types. Some of them related to socio-cultural, some of them related to the vaccination itself, and some of them related to contextual factors. So for the contextual factors here, and actually it is like interchangeably, we can talk about, for example, let me explain this more. Some of the ABI managers mentioned that there are some religious group in Sudan. They believe that these vaccines came from Freemasons companies, okay? And this belief actually inherited in this group, and especially those are radical. And some of these religious group also think that vaccine hesitancy, God can protect us, so there is no need to vaccinate our children. Other factors, for example, in tribal, there are some tribal and ethnic groups. They think that these vaccines is not part of their culture, so they don't need to vaccinate their children, and they prefer to use herbal medicines and so on. Other groups also, if you look at the highly educated people here in Sudan also, some of them refuse to vaccinate their children because they may think that those who come to vaccinate their children are not from the same group, so they refuse to get vaccinated their children. At the same time, they prefer to go to, for example, pediatrician rather than to go to the community health workers.
Thank you very much, dear candidate, and I give the floor back to the pro-rector.
Thank you very much, Dr. Madri. The opposition will be continued by Professor Reddy, She is affiliated with the Center for Critical Research on Race and Identity of the University of KwaZulu-Natal in South Africa. Professor Reddy.
Thank you, Pro-Rector. It's good to be here. This morning, I'm asking questions on behalf of myself and on behalf of my colleague, Dr. Reiter. So I'm going to talk to the candidate as both of us and integrate the questions for simplicity of response. Thank you. Dear candidate, it was with great pleasure that we read your PhD work, and it would have been even a greater pleasure for Dr. Reiter to join today, but unfortunately he was not able to. So we found that you conducted a nice set of studies in the health domain that has been broadly studied in health psychology literature, but indeed much less so in Sudan and in Southern Africa in general. Therefore, your work is very important and very relevant. And interestingly, this set of papers and this thesis was put together in a sense, or the data collection, before the outbreak of the COVID pandemic. So it's good to see that this work is being done in Sudan. This work can also serve as a basis for future research into vaccine acceptance in Sudan, and maybe the rest of us in Southern Africa can learn. The topic is continuously relevant as the vaccines are lifesavers, as we know, and as you've mentioned in your thesis. Together with the good functioning sanitation system, easy accessibility to medication, it's one of those three pillars that strongly determine the health of a nation's population. And we know sanitation, medication, and vaccination make up those three pillars. So again, congratulations to you and your supervisors for approaching this topic. As I said, with the COVID-19 pandemic gaining a good and detailed understanding of what makes people accept or not accept a vaccine, or even half accept a vaccine, that understanding to develop and inform any educational program, be it an app, a website, an interpersonal education program where people don't have access, is important to counter these beliefs. So what we've seen is that across the globe, many studies have been conducted into exploring the determinants of vaccine hesitancy, and typically these studies have all been identifying personal factors that can be changed through some form of informational or health education intervention. These factors are typically called the psychosocial determinants. And this means that factors that reflect people's thoughts, people's opinions, and how that relates to their anticipated outcomes, how they see their perceived risks, etc., and whether people will ultimately take the vaccine or not take the vaccine. Dr. Reiter goes on here to say that these psychosocial concepts are referred to as attitude, the subjective norm, the perceived behavioral capability, or self-efficacy, and are often, and in a sense almost always, defined in a theoretical model to explain this behavior, such as two important ones that we use a lot in our work is the health belief model, theory of planned behavior. However, in your dissertation and in your set of papers, we noticed that these models are not necessarily used, but also other psychosocial models, such as the protection motivation theory, the social cognitive theory, are not mentioned. So Dr. Reiter asks a simple question: why not? Would using these models not provide you with a highly relevant information that could also be used to help select the content of the website? And that was where my question was. How did you develop the content of the website? So I'll let you respond, and then I can ask a little more as we enter into this discussion, because I think I have longer time because I'm covering two professors here. Thank you, candidate.
Thank you very much, high esteemed opponent. Yes, thank you for your compliment. Actually, for the first question, yes, vaccine hesitancy, it was like introduced recently in the literature, and that is why WHO's strategic working group on immunization tried to put more effort to develop many and to unify the models and frameworks to address this issue globally. And yes, and when I started my PhD, actually, I tried to look at this issue from different perspectives, from the perspective of psychosocial model, and also try to use to think more about how can I use this framework or that already developed by WHO. And actually, I found that it is better because this is the first study in Sudan, and maybe at that time was first studies in developing countries about vaccine hesitancy itself as a term. So I tried to use a framework that already well known, well established, well tested to address this very important issue at that time.
So sorry, can I interrupt you? This WHO framework, could you talk about it a little bit and explain? Because from reading your various chapters, it would appear to me, and sorry, I've read your full thesis a long time ago, but yesterday I read the chapter on intervention development. So that's very clear in my mind. It would appear that the WHO framework, with all due respect, is very good, but I'm not quite sure that it deals with the psychosocial behavioral aspects, and I'm not quite sure that it has a theoretical model the way we apply it in health promotion and health education. So you want to comment on that? It doesn't mean that your work is, I still value this work and I think it's very important, but I do think bringing in the psychosocial component or the psychosocial models of behavior and behavior change would perhaps direct us on the continent in a more specific direction. And I'd like to hear your voice on that.
Okay, great. Thank you. Yes, actually, WHO has two models. The first one is broad, which is talked about the determinants of measles, about vaccine hesitancy. And this actually divided into three groups determinants: contextual, social and individual groups, and the final is the vaccination related issue. Okay, this is the broad one. And the second one is some extent very narrow. It is talked about complacency, it's talked about convenience and confidence. Okay, so it is called 3C model. Confidence.
Yes, I saw that.
Yes.
Yes.
And then this model actually now some researchers try to add collection of information and also social what is called as like people when they vaccinate their children because of the others to increase the herd immunity and so on. So
normative.
It is, yes.
Yeah. Social norms, yeah.
Yes. So this now is five model. Actually, from the beginning, vaccine hesitancy what was much debated among scholars, and even this vaccine hesitancy definition actually was criticized by many scholars, and even they may think that even convenience should not be there because convenience is a barrier. They talk here about barrier. But when they talk about others like confidence, like complacency, this means that there is psychological aspect of the vaccine hesitancy. So that is why they think that convenience should not be there. But our study now, and actually this may add to the literature, that convenience and access issue are part and should be part of vaccine hesitancy model, because from our studies we found that perceiving access issue led many parents to not take their children to vaccinate them. So actually, it is much debated issue, vaccine hesitancy, and I think yes, they are now, and even WHO now actually developed a new model.
Excuse me, I have to interrupt you because we have to move on to the following opponent. Thank you very much.
Thank you, Pro-Rector.
Thank you, Professor Reddy. The opposition will be continued by Professor Nanne de Vries. He is Professor of Health Promotion and Education at Maastricht University. Professor de Vries.
Thank you, Mr. Pro-Rector. Let me be short in my congratulations. I think everybody is very happy, has been very happy to read your thesis, but we are running out of time. So I'll just press on, and probably you'll get an opportunity to even continue or to follow up on the answers to Professor Reddy, because I would like to talk to you about the convenience factor. And indeed, I also prepared, there's many models that say, okay, there's attitudes and beliefs, there's social normative factors, and the third type of factor that is very important in determining behavior is something called self-efficacy or control or whatever. And that relates, I think, to the convenience factor. Now, the convenience factor is not recognized in your work. It does not pop up in chapter 3. Whereas I think it is an important factor. So I think you already said something about why it is a bit the odd one out. But if I look in your chapter 4, I think, where you also have qualitative remarks from the parents, many of the convenience factors are actually being named. So I don't really understand what happened here. Could you please explain?
Thank you very much, highly esteemed opponent. Yes, convenience, actually, yes, it is a complex issue. And this appeared actually in our study. Let me explain this briefly. Measles vaccine is presented in Sudan in 10 doses per vial. Okay, and then the vaccine providers not opened this vial unless there is enough children on that session. So they only restrict opening for conducting only one session per week. Because they fear that this may cause wastage of vaccine, and this will be responsibility. So parents, when they try to come to the center, and in a day that there is not the vaccine session of measles, so the vaccinator will refuse to open that vial. So the parents turn away and will not come again because they already paid for transportation and so on. That's why this is causing the hesitancy and not coming back to our delaying the vaccination.
Can I ask, would it really be hesitancy or just unaccessibility or unavailability, or indeed coming at the wrong moment, not easy to reach, not fitting with daily schedules, etc.? So that is sort of an impossibility factor rather than, let's say, the hesitancy of the parents. It is just made impossible, and that explains for the 4% persons in your sample that did not take the vaccine, because it's only 4%, isn't it?
Yes, actually, yes. Thank you again. Yes, actually, parents are actively trying to get the vaccine. okay, they will go to that center and they will not find that day of the vaccine session. They will not come again because the social factors, like they have many filtering, they are very busy, will not put this issue as a priority. So will not go, will not come back again because they have another issues that they should.
But in terms of intervention, I would then rather think about opening up the centers or creating a structure in which people can indeed access the vaccination, rather than doing a public campaign convincing people that it is necessary and efficient to take the vaccine.
Yeah, actually, yes. Here, our study informed that there is a need to change this policy from 10 doses per vial to 5 doses at least, because this will allow opening these vials many days per week. Yes, I agree with you. There is a need to change the policy rather than doing campaign to convince people to come to their children. Yes, so it is a very complex issue. Yeah.
Yeah, and then to finalize, I think, because otherwise somebody gets nervous. Would there be a big difference, because you did your work in Omdurman? I think even 3 studies with the same respondents, so that is a little, well, that's a little bit of a critical remark actually. But if you go out to the more rural areas, so for instance southern Kordofan or the Red Sea area, or that would even be more of a problem, I think, because there's less concentration of the population. So I would say in terms of health promotion, that maybe some structural measures would be more in place than actually a population-oriented one. Would you agree? Sorry.
Yes, I agree with you. Yes, I agree with you. Yes.
Okay, then I still have one other question, because you did a factor analysis to see what are the factors within the scale for hesitancy. And then convenience doesn't pop up. That's normal because there's only one item referring to that. And then I see the adjusted scale, and actually in the adjusted scale, I don't see anything referring to convenience. So maybe it is also your own method that makes it drop out. And that's my final question.
Yeah, actually, yes. As I mentioned earlier, that vaccine hesitancy, and this is one of our findings, that vaccine hesitancy should not be measured by one metric, because, as you mentioned, these scales has some limitations. So that is why we contacted and asked parents open questions about why they don't go to get vaccine.
Yes, I understand, but indeed, also bringing everything back into one PACV score might limit the, let's say, the predictive value of that score, because it is a multidimensional concept. So I'll leave it to that and give the floor back to the pro-rector. Thank you very much.
Thank you, Professor De Vries. The opposition will be continued by Dr. Haukes. She is Associate Professor at the Department of Social Medicine at Maastricht University. Dr. Haukes.
All right, thank you, Pro-Rector. Dear candidates, first of all, I would like to concur with the previous speakers to already congratulate you on your fine and relevant PhD thesis. I also would like to include the promotion team in these congratulations. 4 chapters have already been published. I have read your thesis with great interest. It has been mentioned before, it's very relevant, and the study provides valuable insights into determinants of vaccine hesitancy, but also vaccine uptake in Sudan. And it describes opportunities for increasing vaccine acceptance, which have already been discussed a bit. You have used a mixed method approach, and you use both quantitative and qualitative research methods, which is also a valuable asset of this project. I think we can conclude that vaccine hesitancy and vaccine uptake in Sudan are complex constructs, which are determined by numerous factors on various levels. And particularly in a differentiated country such as Sudan, with the people living in all kinds of social and religious groups, it's a very difficult issue. I had a couple of questions prepared, some of which have already been touched upon. So I will start with a question about chapter 6. And if we still have time, we can move on to the other questions as well. So scrolling down. a little bit. In chapter 6, you described the development of a web-based intervention to increase vaccine uptake in Sudan. And I have a couple of questions about that, and it was proposed we do not ask all questions at once, so I will go through them one by one. The description in the chapter, it's very much focused on the development process. So how are you going to develop, and also about web design, you use a framework on web design, but it's a bit less focused on the content of the intervention. And I think Professor Reddy also wanted to ask the question, but she ran out of time. So my first question is, what do you propose to be the content of this website? What kind of materials, what kind of information, what kind of message will be presented on this website?
Okay, thank you, esteemed opponent, for your question. Yes, we used actually conducted another study, but it is not in this thesis. It is part of my master's student thesis about information seeking behavior, how people seek information, what contents, and so on. So that we depend mainly about this issue, about the findings of this study. Secondly, we also depend on our findings itself, because here we talk about attitude, beliefs, misperception, misinformation, and so on. That's what come up in our studies. Thirdly, we also use the vaccine safety net criteria. Actually, vaccine safety net is a WHO WHO project, and actually to be a member, you should address some issues related to vaccine safety. So this is the third source of our contents.
All right. Okay, and maybe a question about the second component you mentioned, that people can be misinformed about vaccines. How do you imagine to convince people who are misinformed with the right information? So how do you use the website to convince them that the information they might already have is wrong or incorrect? How do you imagine to get the message about the correct information, to get it across to the people? Maybe in line with what has been asked before, we are aware of health promotion, health education theories about attitude, beliefs, and so on. Do you consider to use these theories in preparing the content of the website, getting the message across?
Yeah, thank you again for your question. Yes, actually, we used, or we believe that, and this was already addressed in many studies, that people in Sudan are very lazy to seek for information. Okay? In website. So we also used a Facebook page to those who are passively search for information. Yes, just to target them and giving them information about all aspects of vaccines and immunization. And the website actually addressing issues related to people who are actively search for information in the website, in the Google, for example. So yes, this is one aspect. The second aspect is that we try to use social marketing as a model to promote our website, and this will be conducted by our team in the coming year, in the coming weeks, to promote vaccine website. At the same time, we think that we need to develop like application, mobile application, because this also we found this aspect also were respected in Sudan, and people like to use application rather than website itself. So yes, this is my answer for your question.
Yeah, I think that's an interesting suggestion, because I think what we found also in the other chapters that people with vaccine hesitancy or people who do not uptake, it's a varied group, right? Some people really have doubts about the vaccination. Some are anti-vaccine because of their religious convictions. For some, it's more a matter of convenience. So maybe it would be a good idea to develop different types of interventions to address different specific target groups, because it's not one group, it's a very varied group. So it should be not maybe only a website for active information seekers, but maybe it would be good to develop other types of interventions as well, like public health policies or other access. Maybe you can elaborate on that, and maybe also it would be a good idea to involve the end users in the development of the intervention, because now it's a little bit a top-down approach. You did good studies and you found a lot of information on determinants, but I miss a little bit the voice of the parents and the end users in the development of the interventions, but also in the qualitative study, for instance. So do you think it would be a good idea in the future to involve the parents, the end users more in the development of the interventions?
Yes, thank you for your question. Yes, actually, yes, from the perspective of policy and program level, yes, as we mentioned in our conclusion recommendation, that we need to communicate or to like develop communication strategies to address all these beliefs, all these misinformation and misconceptions about vaccine hesitancy. And this for secondly, also vaccine providers at health centers also, they should be well trained to use interpersonal communication, yes, to address hesitancy of people or of parents about vaccine. And also from another side, that as we mentioned, the reminding system is very important here in Sudan to address the schedule of vaccination, because measles vaccine has very distinct characteristics, that it's given at the 9th month and the 18 months. So this is like a huge gap between the last vaccine in the 4th month and the 9 months. So there is a need to address this issue by using reminding system and to remind parents, to text them, to notify them, and so on. Also,
Mr. Sabahelzain, I'm sure that you have seen that the time available for your thesis, defending your thesis, has passed. The committee will now withdraw to discuss the quality of your thesis and the quality of your defense, and please await our return with the results of our deliberations. Mr. Sabahelzain, the degree committee here present online has assessed the quality of your thesis and the quality of your defense. And in view of this positive verdict and taking into account your previous qualifications, the degree committee has decided to grant you the degree of doctor. Professor Bosma is authorized to confer upon you this academic distinction in accordance with Dutch University custom and law. I invite your supervisor now to take the floor. Professor Bosma.
Yes, thank you. Majdi, do you promise to work in accordance with the principles of scientific integrity at all times, to be careful and honest, transparent, independent, and responsible?
Yes, I promise.
Okay. By the authority vested in us by law and in conformity with the decision of the committee here, present online, I hereby confer upon you, Majdi Mohammed Sabahelzain Dafallah, the degree of doctor and grant you all rights attached by custom and law. As evidence of this, you will soon receive the degree certificate signed by the rector, the secretary, and the supervisor affixed with the official seal of the university, shown by the beadle. Okay, thank you. Now, Majdi, I will do the laudation. Dear Majdi, you always call us Professor Bart and Professor Hans and Dr. Mohammed. So it's now time to switch from Majdi to Dr. Majdi. A great accomplishment. You wrote an excellent PhD thesis, did quite some advanced quantitative and qualitative analysis, extended your network, and built an important website. 4 papers are published and others are in press. Next to the PhD trajectory, you managed to publish on genital mutilation, sickle cell disease, and the politics of COVID-19 vaccine confidence. It shows you have developed into a broad public health researcher, a researcher who is also eager to improve the health situation of people in Sudan. I think the rest of the world can also learn from your work. So many more people, also from other countries, may also benefit from your work. Your thesis is about vaccine hesitancy in Sudan, particularly regarding measles vaccines. You have shown that such hesitancy is not widely spread, but still a substantial minority is hesitant getting the vaccine. By pointing to the determinants of hesitancy, you have found important factors that could be addressed in interventions aimed at tackling the hesitancy. Some factors are easy to modify, others are less easy to modify. Problematic is that interventions addressing the less easy to modify factors might ultimately turn out to be the ones that are most effective in improving population health and tackling the hesitancy towards vaccinations. Despite an overrepresentation of university-educated women in your sample, you still found that the low-educated women were more hesitant, although it might not have been statistically significant, but it was really a big difference between high and low-educated women. To me, it again puts forward the importance of education and maybe other factors related to education, what it stands for and what is the reason for the high hesitancy in the low-educated particularly. It might point to the socioeconomic factors that are important for population health. You came to us via Mohammed, who's your co-promoter. That email dates back to June 25, 2016. I saw in our email conversation that we already quickly could build an interesting and that we could easily build on interesting and relevant plans from your own side. That proactive approach has colored your whole PhD trajectory. It was always us reacting to your ideas and plans, both in conceptual and in practical terms. Bart, Mohammed, and I did not need to give you much guidance, as you had the abilities to start new activities and new ideas for research and data collection yourself. We only had to sometimes temper your enthusiasm and help you stick to the primary essentials. This proactive approach, in your case, can be combined with your abilities to always think of how the evidence can be translated into practical use aimed at improving population health. As your supervisors, we are very proud that you, with the help also of Professor Crutzen, have developed such an important website for decreasing people's hesitancy regarding vaccinations. With this profile of yours, we as supervisors think there's really a good prospect for a successful career for you. Personally, I find it unfortunate to only have seen you in person twice. We were already used to Zoom video meetings because we were at such distance. And then came COVID-19 on top of that. It further hindered in-person meetings. Somehow as a team, we still managed to do well, and it did not temper our enthusiasm. I remember also there were times that internet connections were difficult from your side, as Sudan was in a difficult political and economic situation several times during the whole trajectory. I seriously hope for better times for Sudan, but you have shown to persevere in many difficult situations. I hope you keep that resource of effective coping. And what is also important, instead of deploring the less personal video meetings, we should perhaps welcome them. I'm quite sure your enthusiasm and talkativeness would certainly have extended the 1 hour meeting limit that we can set in the Zoom meetings. So I wonder, Zoom in our case might have brought some good things too. Majdi, you have really delivered a great piece of work. You can be proud of that. And therefore, I'd like to congratulate you very much. I'd like also to congratulate your wife, Dr. Howida Hassan Babiker, and your 3 children, Amr, Yasmin, and Lane. I wish you a good further career and a good private family life. Your supervisors, Professor Bart and Dr. Mohammed, and myself, know that you have the abilities to fare well. So, Dr. Majdi, we wish you a farewell, but let us stay in touch as well. Keep letting us know how to improve population health in Sudan, but also elsewhere. Congratulations, Dr. Majdi.
Thank you very much.
Esteemed Dr. Sabahelzain, dear Majdi, it's my great pleasure to congratulate you with your doctorate and the honor that you have required today. And I do that also on behalf of the Board of Deans of Maastricht University. And I also would like to share some impressions from the degree committee. And of course, you may have seen and heard that the committee had some critical remarks on the thesis and on your defense. But on the other hand, we are also very aware of the difficult conditions that were during doing your study. And we have seen that it was not easy to do this type of research in the area that you did it. But we are very satisfied with your thesis and also very satisfied with your defense. And I would like to congratulate your 3 supervisors with this result. And Professor Hans Bosma, Professor Bart van der Borne, and Dr. Mohammed Boukier, congratulations with the results that we have seen today in the form of a very good thesis, the publications, and a good presentation, a clear presentation. Thank you. You can be proud on that, and thank you very much for your input and your support during this study. And of course, I will also include in my congratulations your wife and 3 children, and also the other members of your family, your parents and your brothers and sisters and other members of the family. And of course, I also include your colleagues and your friends and all those who have contributed to your studies that we have seen in your thesis. And I wish you a successful professional career and a happy personal life. Before I close this ceremony, I would like to thank all the members of the thesis assessment committee and of this degree committee, and in particular the external members. And I thank you all very much for your questions, your input, and the interesting discussion that we have done today during the opposition and during the ceremony. And Maastricht University appreciates your input. And hereby I close this academic ceremony.